Welcome back. So we are about to begin one of the most exciting segments in this program, which is rapid fire session in Neuro Ophthalmology. To lead this dynamic session, we are honored to have with us Dr. Aruna Fernando, consultant vitreoretinal surgeon, senior lecturer, and head of Department of Ophthalmology at Kothalaval Defence University. So please join with me welcoming Dr. Aruna Fernando to take over the session.
Thank you very much. Welcome everyone after the tea break. We are going to start the session on neuro-ophthalmology and we are joined today by an expert group of panelists. I'll just introduce them to you. They actually don't need any introduction, but I will be mentioning our panelists now. Dr. Bimsara Senanayaka is a senior consultant neurologist. He is attached to the National Hospital of Sri Lanka. And Dr. Ali Boy doesn't need an introduction as well. He's quite a well-known and a very reputed neurologist practicing in the private sector. Then we have Dr. Deepani. Doesn't need any introduction at all, known to all of you, and Dr. Nalin Rajakaruna, who's joining joining us from the Ragama Teaching Hospital. We are also joined by Dr. Rashmin Gandhi. He's the consultant and director of the Department of Neuro-Ophthalmology, Center of Sight, Hyderabad, and Professor Dan Milia, who will be joining us again online. He's the neuro-ophthalmologist from the Singapore National Eye Center. So I'll just mention how this session is supposed to run in just 1 minute, because this is a new format that we have tried to introduce to cover a large number of topics in a short period of time. So each of the topic is allocated roughly 5 minutes. So a panelist would be answering 3 to 4 questions in one session. And we will have a few minutes at the end of the talk, maybe to have a discussion, depending on the time. And because it's quite a rapid session, I'll try to coordinate it and manage the time as we go along. So the first to start the session would be Dr. Bimsara Senanayaka. So please, if you would like to take the podium. If he can have his slides on. So the first question that he is going to be answering is, how would you investigate a person with bilateral symmetrical temporal disc pallor with centrocecal scotoma? Over to you, sir.
Thank you very much. I thank the college and the president, and especially Deepani for inviting me for this segment of today's meeting. So the first question is on how to investigate a person who's having bilateral symmetrical temporal pallor with central scotoma. Now, when you have this clinical scenario, the possible underlying diagnosis would be optic neuropathy. The causes could be many. So what is important is to investigate and try to find out whether we would be able to get to the bottom of it and get to a cause, so that we would be able to at least prevent progression of the condition and to salvage vision as much as possible. So there are many causes that can lead to bilateral temporal pallor in a patient. So our intention is mainly to investigate so that we can prevent further deterioration and optic atrophy and visual impairment and blindness. So there are many underlying causes, as I mentioned. So it could be an inflammatory cause like optic neuritis, which is typically seen in multiple sclerosis and also the atypical forms in neuromyelitis optica spectrum disorder, MOG disease, and cryons and other inflammatory immune-driven causes of optic neuritis. It could be post-vaccination, vascular causes, arthritic or non-arthritic causes, toxins, alcohol-related and drug-related, and also nutritional causes like B12, and also compressive causes as well, like meningiomas, gliomas, brain tumors, which can lead to this condition, and infections, infiltrative causes, and of course trauma and hereditary causes. So there are many causes which can give rise to this clinical scenario of bilateral temporal pallor. So one has to investigate all these patients in order to find out what the underlying cause is. It's important because, as I said before, to ensure that underlying cause is found and do everything possible to prevent further deterioration and salvage vision as much as possible. So the brain imaging is important in all cases. So it's important to find out the brain parenchymal changes as well as the orbits, dedicated orbital cuts with fat suppression, stir sequencing, to see contrast enhancement in T1 and the other changes. And OCT, again, there can be certain fixed patterns, and other investigations like fluorescent angiogram, MRI, spine is done in certain cases where we are suspecting conditions such as neuromyelitis optica spectrum disorder. So there are many conditions which can, as I said, can lead to this situation, like meningiomas, other compressive lesions, adenomas, aneurysms, and so on, and the inflammatory causes as depicted here. So the other investigations include the neurophysiology. We look at the visual evoked potentials and whether there is a demyelinating pattern, delay in P100s, or whether there is evidence of axonal damage, like in other conditions like ischemia, nutrition-related problems and toxins, and so on. So there can be various visual field defects associated with these problems. And accordingly, the serology also has to be done. The antibody testing, aquaporin 4 MOG testing, and the basic investigations, other bloods, and so on. So these are the investigations we do, genetics, CSF, vascular screening as well is done.
Thank you, sir. Right, for the next question, a young patient with a newly diagnosed optic neuritis, having testing and treated, should he be tested and be investigated for multiple sclerosis? So that's the question. Young patient with optic neuritis, should they all be tested and treated for multiple sclerosis?
Thank you very much again. And yeah, this is an important question because these patients are usually seen first by you in the eye hospital, and the patients come with a visual impairment, painful maybe, and all patients with such presentations, the optic neuritis, which in the typical form is where you get unilateral short segment lesions in the optic nerve with, it is majority of the cases retrobulbar. There could be disc edema, which is mild, and about 25% of MS patients at presentation have optic neuritis as the first manifestation, and presence of brain abnormality in MRI will definitely increase the possibility of these patients getting MS later on in life. So all patients with first episode optic neuritis should be investigated. So there is no exception there. All patients should be investigated because that could be the beginning of a more sinister problem which is underlying, and it could be the first episode of multiple sclerosis or other related CNS inflammatory demyelinating disorder. So according to the findings we had in our series of patients, nearly 51% of our MOGAD patients actually for the first time presented with optic neuritis alone, and about 34% of our MS patients also presented for the first time with optic neuritis. So all these patients, unless they were investigated, we would have missed the diagnosis of multiple sclerosis, MOGAD, or in some cases, aquaporin 4-driven NMOSD as well. So it is important to consider all patients to be investigated, and there is this ICON criteria where we can, the optic neuritis can be either immune-driven, the optic neuritis, or it could be infectious as well. So some of these investigations are listed here, aquaporin 4, MOG, and so on. And also the infections, multiple infections can give rise to optic neuritis as well. So some of these conditions also might have to be investigated in these patients. So there are criteria now from this ICON 2022, which basically there are clinical criteria and paraclinical criteria as listed there. So the paraclinical criteria includes OCT, MRI, and biomarkers. So these are the investigations. So all patients, basically the message is, all patients with first episode optic neuritis should be investigated further.
Thank you, sir. The next question is actually, I think you have already answered, but the question would be, how urgently would you have to do the neuroimaging and visual evok potential? So here the emphasis on the urgency.
Yeah. So yeah, I think it's another important question. So I would say that within the first 20 days of visual loss, contrast enhancement of the nerve is best seen in a fat suppressed T1 weighted coronal image. So actually the predictive value of optic neuritis by imaging is now over 90% if it is done properly with fat suppressed T1 weighted images, coronal images. So they say it's best done within the first 20 days. So all patients should be investigated as soon as possible with MRI and also with the electrophysiology. So length and the pattern of optic nerve involvement also can give us some idea what type of CNS IDD that we are dealing with, whether it is MS, NMOSD, aquaporin 4, or MOG disease. As you can see in this, the longer lesions that you might see in certain conditions like MOG disease with perineural inflammation, and shorter segment lesions in multiple sclerosis, and more posterior chiasmal lesions which we see in aquaporin 4 related optic neuritis. So these differences in the MRI also will help to differentiate between these conditions. So earlier the better, because most of these conditions can recur. Relapsing disorders they are. So the biggest problem is that the next episode can be a devastating episode with resulting in severe visual impairment as well. So earlier the better to do all the investigations, I would say.
Right. Thank you very much, sir. I think that concludes Dr. Bimsara's questions. Since we have a few minutes, I would like to have the opinion of our rest of our panel as well. The microphone is there. Dr. Aliboy, would you like to add anything to?
Yeah, I think Bimsara has covered most of it. Nothing special. I think just that you must be, very particular about this MRI, because we as neurologists, ask for MRI brain, and that's it most of the time, and we don't focus specifically requests for fat suppressed MRI. So if you don't do that, you're definitely going to miss the optic neuritis and the extent of the optic nerve involvement. So that's one thing. And also with regard to the urgency, I think yes, it's quite urgent to do it. Not only the MRI will tell you not only whether there is optic neuritis, but it also tells you the extent of the disease, whether it's extended into the chiasma or whether the other side is also affected. It will tell you whether there are any demyelinating lesions in the brain itself, and also it will exclude other conditions which are like compressive lesions and things like that, which which are responsible. So I think pituitary lesions and things like that. So I think MRI is very useful. The sooner the better.
Yeah, let me also add that early treatment, aggressive early treatment now, it is proven by number of studies that earlier the better to treat. With the visual outcomes are much better. So there are multiple studies done as well. on that.
Thank you very much, sir. Thanks. So I think a clear message given by Dr. Bimsara and Dr. Aliboy on the management of optic neuro. Thank you very much, sir. So the next speaker would be Dr. Nalin Rajakaruna. Over to you, Dr. Nalin. So he's going to answer first in an interesting question. Probably some of your friends or relatives might have asked you secretly as well. Does erectile dysfunction agents cause anterior ischemic optic neuropathy?
Right. Now, if you give the answer, it is categorized as a possible. It's a possibility. That's about the WHO classification. It doesn't. There are diseases being classified in the WHO classification, where you say, well, definitely you get it, and then they have said, okay, this is a possibility. So we'll see why. Okay. Right. Right. Now, sildenafil, the action is it inhibits the phosphodiesterase type 5 in the smooth muscle relaxation, and then you get a penile vasodilatation. Now, this drug is used for erectile dysfunction as well as for pulmonary hypertension as well. So, because it has a vasodilatation action. So, now as we said, the therapeutic dose can cause a vasodilatation and a systemic hypertension. Right. Now, if this response, the exaggerated physiological nocturnal hypertension, right, it can cause a ischemia to the optic nerve and a compartment syndrome in susceptible patients with a small CD ratio. Right. Right. Now, the thing is, now the age group which use this drug is the age group which usually get the non-arthritic type of ischemic optic neuropathy, and they have the vascular risk factors as well. So it is very difficult to say that it is due to the drug or whether the patient is already having a vascular risk factor because of the common age group between the two, right? And the factors they are known about this drug is doesn't cause a permanent toxic effect. They can have small, minor visual field losses, blurred vision, color vision defects, which will pass away. But the most sinister one is the optic neuropathy in that case. So they have laid down criteria, okay. So if avoid in a patient who had already experienced an NAIO in the other eye, okay, and want to seek medical attention if visual symptoms occur. So that is the current standard, and now evidence does not exist to discourage usage of attribute to harmful ocular side effects. So there's no contraindication. So it has to be like taken by case. So that is why it has been categorized in the possible category.
Thank you, Dr. Nalin. That's possibly maybe a reassuring statement for for our patients as well. So the next question is, does amiodarone produce optic neuropathy?
Yes. Now, this has proven to cause optic neuropathy, right? Right. So, if you take this, so it's called amiodarone-associated optic neuropathy or AAON. So, it is an insidious onset. You don't get in an acute stage, you get it gradually, and you get bilateral visual loss and diswelling and visual field defects. So, it is like a toxic, what Bimsara said. It was a generalized toxic effect causing optic neuropathy. And the duration of amiodarone is for about 9 months. Okay? And the dose is, the median dose is presenting with visual symptom is 200 milligrams per day. And to get optic nerve toxicity, by that time you have developed corneal verticillata. You see this deposition in the cornea causing this pattern. So by the time you get optic nerve toxicity, the cornea has got affected as well. Okay, so that is one way you can you see whether you're getting toxic by looking at the cornea, right? And now the cessation of the drug or dose reduction considered if optic nerve develops, optic neuropathy develops, and 58% of their visual symptoms improve. So at the moment, there's no screening protocol or defined risk stratification strategy. Okay, so it's again a case-by-case thing. There's no like we do for our chloroquine maculopathy. We don't have no screening protocol for this. Okay, and say why you get this is the pathophysiology is like you get lysosome-like intracytoplasmic lamellar inclusions in the large axons of the optic nerve, blocking the exoplasmic flow. So this causes these inclusion bodies to block the exoplasmic flow of the optic nerve, and then it causes the optic neuropathy. So if we compare the AAON or the amyloid-associated optic neuropathy and the non-arthritic ischemic optic neuropathy, there are some differences. So amiodarone neuropathy, it's a male preponderance is seen, where NAION, there's no sex predilection. And this is an insidious onset, that is a more acute onset, and a slow progression in AAON. We said it takes about 9 months. And here the NAION, it progresses fast. And it is a systemic disease, so systemic problem. So you can have unilateral and later bilateral, but usually it's a bilateral one. NAION usually is a unilateral one. And disc hemorrhages are usually seen in the NAION, but you don't see it commonly in AAON. And if you look at the optic nerve morphology, you get a normal disc morphology. Here you get a small crowded disc. Okay, so especially looking at the other side. And this disc swelling is protracted in AAON. I said it's a long duration one, where here it resolves in a shorter period of time. So that's how you can differentiate these two.
Okay. Dr. Nalin, if I ask a question, considering the seriousness of the neuropathy, do you think there should be a screening protocol for patients who take chemical?
I really don't know how frequently they use the amiodarone for antiarrhythmic, whether they have new drugs for this. So if it is being used frequently, I think it is a good thing for the cardiologist to know that these things can happen in the optic nerve. Definitely it is recorded.
Yes, and considering the fact that it can easily be detected by just looking at the cornea.
Look at the cornea, that is when the toxic levels comes.
Exactly. So maybe something to look into in the future.
Review might be a good thing, like we refer the patients for the HCQ retinopathy.
Yeah, but we don't need to do a lot of investigations like for HCQ. Here we just need to look at the cornea. Yeah. Right, thank you. So going on to a slightly different topic. Here we are talking about traumatic optic neuropathy. Should we treat it?
Right, okay. So back again, we are with not a proper yes or no. It's a debatable one, whether I should treat optic neuropathy or not. So we'll see how it can be caused. It can be caused due to direct injury to the optic nerve, most common, or indirect or direct. Okay. So diagnosis is mainly a clinical diagnosis supported by radiographic evaluation. So what are the treatment options we have? One thing is you keep the patient under observation, and they have found out spontaneous recovery occurs in about 50 to 30% of patients. Then we get into the medical therapy. Corticosteroids is the drug of choice we use there. You use IV infusion of methylprednisolone, 30 milligrams per kilogram, and a maintaining dose of 5.4 milligrams per kilogram for 48 hours, and to start it within 8 hours of the injury. Right. And now there is another medical management coming on. It's called intravenous erythropoietin. So they say you can reduce the action of erythropoietin is to reduce the apoptosis in neurons, and so they test some neuroprotective action on the nerve. So there's no definites, there are a lot of studies to be done to make this and say that it is only thing the toxic effects of methylprednisolone will be less if we use the IV erythropoietin, but there's no clear-cut thing to say that erythropoietin is the drug of choice. Right. Then we have the surgery, that's the optic nerve decompression, especially extracranial, or you can do it endoscopically, or you can have a combined therapy. Right. Now, evidence supports the benefits of this treatment in improving visual acuity is lacking. So there is no evidence to say that it is the visual acuity is improving. Right. So then the decision to treat should be individualized based on the clinical presentation, imaging findings, and weighing the risk and benefits of each treatment options. So it is again individually based, it's on the discretion of the person who is treating. So, but there are a few points they said, like these are the bad prognostic finds. It's like at presentation, if your vision is very low, or your recovery is low, or you have radiographic evidence of the optic nerve canal, there is a fracture. So those features will tell whether or your initial visual acuity is less. Those are factors will have a bad prognosis.
Dr. Nayan, would you consider the age of the patient when you think of
I think it's
treatment
all
options?
these, mostly these just happen with whatever the studies are with young patients. It's like a traumatic thing. So, but there's nothing to say that age is a factor you should consider. So I have not come across any evidence to bring that factor to see whether the age is a factor to treat it. Maybe with the methylprednisolone, putting a patient on methylprednisolone in an older patient may be not very beneficial, so maybe that factor. But age, they won't consider age as a factor.
Can I ask from our neurologist regarding the use of erythropoietin? Is that used? Is that something that you come across?
No, I haven't actually personally used erythropoietin for treating Ali. I think this is something new. We have used steroids, but not.
Yes. Right. Thank you. The next question is going to be again will be answered by Dr. Nalin. So here we are asking about a young patient with transient visual loss. So this is something that we call the amaurosis fugax. Should we perform carotid Doppler and cardiac echo on all these patients who present like this?
Right. So the answer is yes. Right. So if you take the causes of transient visual loss, it can be monocular or binocular. So most likely cause of a transient monocular visual loss is a retinal ischemia, which lasts for about few seconds to minutes and followed by a full recovery. Right. So it has to be differentiated from structural optic disc and intraocular causes, which can cause this. Okay. Like impending central retinal vein occlusions, optic detrussions, or papilledema. Right. Now, if you take causes of the transient monocular visual loss, mostly it's a vascular one. So vascular can be a carotid pathology or carotid embolic sources, giant cell arteritis, or vasospasm. Or it can be a neurological cause. It is retinal migraine, or ophthalmic cause like papilledema, optic distrusions, or intermittent angle closure glaucoma. They can come with a transient visual loss. Right. So as we know, ocular ischemia caused by the embolism in the ophthalmic artery and the branches that feed the retina and the optic nerve. So the source can be from the heart, aorta, or ipsilateral, extracranial, and siphon portions of the internal carotid artery and the ophthalmic artery. So the investigations is these carotid, you see the detecting the occlusion, duplex ultrasound scanning has a sensitivity of 96% and a specificity of 100%. And the echocardiogram can aid the locating the emboli, source of dye from whether it's a heart, aorta, and it is also useful in detecting valvular and cardiac wall defects and intracardiac tumors which can throw emboli. So if you get a young patient with transient ischemic loss of vision, I think we need to do, because we know ischemia is the most common form, and from that the embolism, so it will need carotid duplex scan and echocardiogram to exclude any embolic phenomena.
Thank you, Dr. Nalin. Would Dr. Dipani like to add anything to the?
Not to add, but actually a question, like most of the time the patients with traumatic optic neuropathy presents to us a little late. But sometimes we try to give the benefit of the doubt to the patient and give what is your what's your experience?
Yes. My experience, of course, what I practice is if they come late, I don't give them. But there is, what I've seen is it's been done as well. I think they give the benefit of the doubt to the patient and give it. I don't know what is the percentage when they are given late. What they say is you have to do it quickly. You have to do within 6 to 8 hours after the injury. We get the patients about 48 hours after that. So we really don't know whether they are having the spontaneous recovery or whether it is the action of the steroids.
May I also add to that even in acute spinal injury, earlier the better, but sometimes we see some response afterwards. As you say, like we don't know whether it's the steroids or not.
Yeah.
It is said that it is best done within the first few hours, but sometimes it works afterwards. Also in acute spinal injury. So most of the time they are not operated on, so we can use IV steroids.
Right. Thank you.
So probably, though the steroids do carry side effects, the benefit of the doubt is given to the patient if they arrive early, and we should treat. Yeah, so that's the message. Okay, thank you, Dr. Nalin, for a very enlightening session. I would like to invite Dr. Aliboy for his questions. The first two questions are actually related, so I'll state those two together so that he can answer, taking about 10 minutes. Should I do a MRI or a MRV, magnetic resonance tomography, in a patient with idiopathic intracranial hypertension? And the second part of that is, does idiopathic intracranial hypertension exist? Does idiopathic intracranial hypertension without papilledema exist? So these two questions on idiopathic intracranial hypertension.
Good morning. Firstly, let me thank the College of Ophthalmologists for inviting me to participate in this session. So the first two questions, as mentioned,
Next slide, please.
So the first question, should an MRI and MRV brain be done in a patient with idiopathic intracranial hypertension, IIH? So the answer is yes. So we'll take the MRI first. So should an MRI be done in IIH? As you know, in the diagnosis of IIH, neuroimaging is essential, especially in anybody who has papilledema. Patients with IIH will present with papilledema, and some sort of a neuroimaging is required, ideally an MRI brain. And the reason why you do an MRI is to exclude any structural lesions within the brain. So we are looking for space-occupying lesions, hydrocephalus, any meningeal enhancement, or cerebral venous thrombosis. So once you excluded all of these, then you would label this patient possibly of having IIH. Anyway, MRI can also be useful because it can also show some features of raised intracranial pressure. So MRI is required in IIH. Is MRV required? Okay, so there are two reasons why you might want to do an MRV. The primary reason is to look for evidence of cerebral venous sinus thrombosis. So MRV again is not always indicated in patients with IIH, especially in the typical patients who are obese and female in the childbearing age, say between 20 to 40. Chances of venous thrombosis is rare. So sometimes you may not do it in these patients if there is a problem with cost. But additional cost isn't much, so most often we request for MRI and MRV in all patients. But definitely MRV is indicated in atypical patients. For example, non-obese, if you have a thin person getting IIH, something you need to look for, possibly of venous thrombosis. Similarly, people who are not in the childbearing age and also in males. So, so that's one reason why you would want an MRV. The second reason is that MRV would also show evidence of what is called cerebral venous sinus stenosis. Often we see stenosis of the transverse sinuses, either unilateral or bilateral. And this is, probably one of the causes for developing of raised intracranial pressure because there is an obstruction to venous flow and that increases intracranial pressure. And therefore, if you find evidence of especially bilateral cerebral venous stenosis, there is always a place for stenting, which has become, although we don't practice here, it is supposed to be safe, effective, and minimally invasive procedure. So both MRI and MRV are useful in patients with IIH. So going to the next question, then can you get, does IIH without papilledema exist? So I would say yes, but it's quite rare. So what's the situation like here? So usually you have a patient, with headaches, and then you look at the fundus and you see papilledema, and you have done a scan and you excluded anything within, and you label this patient possibly IIH. But here, when would you get a patient, when will you think of a patient having IIH without papilledema? Okay, so you have a patient where you've been investigating these patients for headaches and tried all the possible things, all the possibilities, and then you come to a very refractory patient who you have no explanation probably, and then you might then think, okay, is this possible where this patient has raised intracranial pressure, but the scans are looking normal and there is no papilledema. But the thing is, so what would you do? You will have to go back and look at your scans or do the MRI and look at the scans to look for these fine changes that you see with raised intracranial pressure. Usually you don't see these changes. These changes are not reported by the radiologist, but unless you look for very carefully. So some of these changes are that there is a protrusion of the optic nerve head, flattening of the posterior globe of the flattening of the posterior aspect of the globe. There is distension of the subarachnoid space around the optic nerve. There is increased tortuosity of the optic nerve, empty sella, and a transverse sinus stenosis. So once you suspect, okay, this patient doesn't have papilledema, but on the MRI, if you feel that there are some changes to suggest that this MRI shows evidence of raised intracranial pressure, then you will have to confirm that. And how do you confirm? Only way is to do a lumbar puncture. So when you perform a lumbar puncture, you look at the opening pressure, and normally normal pressure is less than 200 millimeters CSF. So elevated CSF pressure is between 200 to 250. The criteria that they take for IIH is any pressure more than 250 millimeters CSF. But it's very important now in these patients, you have to be sure how you do this procedure, because the way it's done in the ward, sometimes we don't have manometry, manometers to check the pressure properly. It's done with saline tubes and things like that. So you have to be very careful because you are fully dependent on the recording of your lumbar puncture pressure to get this diagnosis. So your technique has to be correct when you do the lumbar puncture. And also you have to be sure that the lumbar puncture composition, the CSF composition is normal in these patients, right? So that's also important to know. So then, if the pressure is elevated, then you will come to a situation where, you have a raised intracranial pressure confirmed by a lumbar puncture. So then the question is, can there be, this question which I am asked, can there be a raised ICP without papilledema? So we have seen patients with unilateral papilledema. We have reported a case in practical neurology of a patient with unilateral papilledema. So that's easy because when you have a papilledema in one eye and then the other eye doesn't show, doesn't show papilledema, that's easier to diagnose than when you don't have anything. When your eyes are normal but you have raised intracranial pressure, it's a more challenging diagnosis. But this can happen. So if you can have unilateral papilledema, you can have raised intracranial pressure without papilledema. Explanations for this is there are some anatomical variations, anomalies where the optic nerve sheath prevents the transmission of the CSF pressure onto the optic nerve and prevents development of papilledema. Also the possibility that the MRI changes have developed before the papilledema has developed. Right? So the MRI changes may have come first and the papilledema has not yet developed and the patient has raised intracranial pressure. So it is essential to consider this diagnosis. It's challenging to make a diagnosis like that, and this condition is rare, so you have to be careful before you make a diagnosis.
Thank you, Dr. Aliboy. I think that a very interesting talk on papilledema. I think the take-home message is, if there is papilledema, always investigate. And even in the absence of papilledema, if you have the signs that you mentioned and the symptoms, to investigate. For ophthalmologists, probably the most difficult thing is sometimes in challenging cases to diagnose papilledema. I remember when I was in training, a neuro-ophthalmologist did a 1-hour lecture on diagnosis and confounding appearances of papilledema. By the end of the 1 hour, still we were left with a lot of questions. So certain conditions with optic disc drusen, small discs, tilted discs sometimes confuse papilledema. I'm just taking a couple of more seconds from your talk. I think currently, even at the moment, I'm managing a patient who has a confirmed diagnosis of idiopathic intracranial hypertension, which doesn't show a typical papilledema. I discussed this case with Dr. Deepani as well, and it's sometimes a little confounding. So I think we have to keep an open mind as ophthalmologists, and maybe read up on it as well and follow these cases up, because we do not want to miss this as well. So the next question is something a little different. Question is, should I start steroids for patients with myasthenia gravis to reduce the chance of generalized myasthenia? So I think the question is on patients with ocular myasthenia. Should you start steroids to reduce the development of generalized myasthenia?
So I would say yes in this question. So just going back to myasthenia, ocular myasthenia, the biggest problem is the symptoms. The symptoms are limited to the eye, and the biggest problem is this diplopia and ptosis, because these are very annoying and uncomfortable symptoms. It will affect your daily activities like driving, reading, walking, and so that is important. Although it's mild myasthenia, it's not life-threatening, but it is real nuisance. Second thing is that there is always a possibility of progression of ocular myasthenia to generalized myasthenia, and usually it does so within 2 years of the onset. And it is said, the figures are very variable, but it's about 50 to 75% of the ocular myasthenics can progress to generalized myasthenia. And if it does, then you have much more problems where it can impair the quality of life and also be very life-threatening. So your treatment goals when you treat a myasthenia is, first in the ocular myasthenia, you have to get your eye alignment back, right, and improve your ptosis and see that you have optimal binocular single vision. And also the second option, second thing in the treatment is to prevent or delay the development of generalized myasthenia from ocular myasthenia. So what you should do is to employ an approach that accomplishes the above with very low risks with your medication. So you have, have drugs which you will not cause too many side effects and prevent and treat the above. So when you are treating myasthenia, you have two options: symptomatic relief with neostigmine and pyridostigmine. This is just treating the symptom not treating the disease itself. So when you do that, there is a lot of fluctuation in the patient's symptoms because it is very symptomatic treatment. Second option is to go for immune-directed therapy, and that has the benefit of preventing the progression of generalized myasthenia. Now, you have two choices there. You have the prednisolone and prednisolone steroid-sparing drugs. So often, you do not need a very high dose of prednisolone. You can start with moderate doses and then tail off to and maintain on a low dose prednisolone. Second option is, if there is a problem with the prednisolone, you can use steroid-sparing drugs. We use azathioprine and mycophenolate, especially if the steroids cannot be lowered to reasonable levels or safe levels, or if they are developing side effects from the steroids. So in that case, then you can go to steroid-sparing drugs. Yep. So I would think that you could use immune therapy to control the symptoms of myasthenia and also prevent the progression to generalized myasthenia.
Thank you, Dr. Aliboy. So the answer is quite very clear. The next question is of a patient with a pupil involving third nerve palsy. So that is the surgical third nerve palsies, as we so call it. So if their MRA and CTA are negative, should you do a digital subtraction angiogram? So surgical third nerve palsy with a negative MRA and a negative CTA, should we do a digital subtraction angiogram?
Yes, so answer is not always, that's my answer, needs a proper selection of your cases, right? So we'll look into that. So firstly, you have this pupil involving third nerve palsy. So whenever you get a patient with a pupil involved third nerve palsy, you must always think, is this a PCOM aneurysm? Because that's an urgent thing, right? So until you prove it otherwise, you will have to keep that in mind that, am I dealing with a PCOM aneurysm? And generally in that case, historically, always previously the gold standard was a DSA. But it has its own risks, right? So it's an invasive procedure, and therefore you have the risk of catheterization, so therefore you can end up with cerebral infarction. You are giving contrast, you can have contrast allergies, and also you can have bleeding and cause local hematomas. So nowadays we have non-invasive procedures, cost-effective, much safer, easy to do, and much equally sensitive neuroimaging like CT angiograms and MRA, which are readily available and now considered the initial test of choice. So if you have a patient with pupil involved third nerve palsy, first thing you would do is to go for a non-invasive procedure. Now, considering the aneurysms and the sizes and the imaging, what is said is that if you have a PCOM aneurysm, it has to grow to a size of about 4 millimeters to start pressing on the third nerve. So to get symptoms of third nerve palsy, the aneurysm size should be at least 4 millimeters. And on the CT and the MRA, they are generally reliable to detect aneurysms more than 3 millimeters or more. So therefore, on that grounds, you should say that CT and MRA would detect your aneurysms if they are coming with third nerve palsies. But CTA and MRA can still miss 5 to 10% of PCOM aneurysms. And that may also be if they are smaller aneurysms, less than 3 millimeters. Depends on the exact location. Sometimes if it's in a situation in a direction that sometimes the CT, MRA can miss. It depends on the quality of scan. It depends on the how and timing of the contrast that was given. And also depends on how the reporting has been done. So on those grounds, you can miss patients with aneurysms just on the CT and MRA. While DSA overcomes many of these shortcomings, and it is much more sensitive and specific. So based on that, how would you answer this question? That should you then do a DSA in all patients who have CT angiogram or MRA negative? What will you do? So you must remember DSA is, although it's a gold standard, there is always risks of complications. So we would say that it should be performed in third nerve palsy only if the risk of harboring a PCOM aneurysm is high even after doing the non-invasive scans, right? So after the CTA, MRA, if you still think that this patient must have an aneurysm, this risk is high that this person has an aneurysm, then there is always a place to go for a DSA. So what are these high-risk patients? Okay, if this patient came with an acute painful third nerve palsy with severe headache and vomiting, then that is a bit of a worrying situation. Even if your CT angiogram is negative, you will say, okay, most likely I will go for a DSA here. Similarly, if there is definite subarachnoid hemorrhage, then has to be a bleed from somewhere. You have to go for a DSA. And similarly, in patients who have family histories of aneurysms, then also maybe there is an indication for a DSA. In the others, with pupil dilated third nerve palsy, here you have done CTE and MRA. The risks of aneurysms is low. What you can do is you can watch to see whether the signs resolve or else new signs develop. So if there is any change, then you can do an interval, again an MRA or CTA. It all depends. It depends on your choice, or else you might go for a DSA at this stage in these other patients. So in conclusion, I would say DSA is invasive procedure and it should be performed based on individual patient characteristics and your clinical judgment at that time.
Thank you, Dr. Aliboy. I think that clearly defines the protocols that one should be following when encountering this important life-threatening condition. Thank you for sticking to time as well, Dr. Aliboy. Thank you again. Now we are going over to our online speakers. Can we have Dr. Rashmin Gandhi? Is he on?
Hi, good morning. Good morning, Dr. Aruna. Good morning.
Hello, good morning, Dr. Rashmin. It's nice to see you again, and thank you for joining us. In the interest of time, we'll go directly to your question. So the first question to you would be, what is the best visual field in terms of neuro-ophthalmology? What should you do? What is the scan that we should be thinking of?
Yeah, thank you, college, and thank you, everybody, for inviting me here. Since we have less time, let me just go into the best visual field in neuro-ophthalmology. Now, there are a few differences between a glaucomatous visual field and a neuro-ophthalmology visual field. There is a big role of confrontation and EMSL charting in patients who have a neuro-ophthalmic problem. Confrontation can pick up 70% of the neuro-ophthalmic visual fields, and the indications for performing a good confrontation test would be a patient who had a neurological issue, a patient who is not going to cooperate, who is not going to sit for 20, 15 minutes, 10, 15, 20 minutes to perform an automated perimetry. Children or patients who are not physically fit, patients who are in the ward. These are the patients where performing a confrontation test will get you the pattern of the vision. The other important indication of doing a confrontation test for our patient would be somebody who has poor visual acuity. To have a meaningful information from an automated perimetry, you need to have a patient with 660 or above vision. A lot of our patients with the problem may have poorer vision, and these are the patients where confrontation will discover the pattern which we are after in patients with neurological problems. EMSL charting is used mainly for a retinal problem, but also can give you information about the central visual field defect. We had a patient who just came with complaints of frequent change of spectacles in a presbyopic age group, and he had changed 4 spectacles in the last 6 months. A very smart optometrist just did the charting and found the patient actually had what is known as homonymous hemiscotoma, small, not the full-blown hemianopia, but a small hemiscotomatous defect closer to the fixation. That was a problem which was causing to have feeding difficulties, and the cause for hemiscotoma was found to be a stroke, a small stroke. So that's about confirmation and Amsler charting. Kinetic visual field, like Goldman perimeter, is what was designed mainly for the neuropathic defects because it can discover the peripheral defects much faster. With the lack of availability of machine or a good technician, this has gone out of vogue. And in fact, we don't do kinetic perimeter because we don't have an access to it now. So now we come to the automated perimeter, which is what is a gold standard now, is being used in most of the visual field examination. Now, what are the different programs which are available to us, and which one would you use? So the difference is always between 24-2, 30-2, 10-2, and the screeners like 60-4 or 120-2. We have to remember that automated perimeter were designed for glaucoma. Now, there is a basic difference between a neurological optic neuropathy and a glaucomatous optic neuropathy. A glaucomatous optic neuropathy is a chronic, lifelong event. So it has to factor in development of cataract, aging changes, and whatnot. So there we have importance given to each and every point, and we look at PSD or pattern standard deviation much more carefully. In a neurological problems, generally it's an acute or subacute event because that's where we use this visual field for diagnosis or to know as an adjunct to the diagnosis. And then we also can use it for a follow-up to see whether the treatment is yielding any results or not. So because of this basic difference, one being an acute or a subacute event and the second being a chronic event, in a neurology, we are looking more at a pattern. So we look at a grayscale and generally look at a grayscale as our lighthouse to see what kind of visual field effect the patient will be having in a neurological problem. And between MD and PSD, that is mean deviation and a pattern standard deviation, a mean deviation would give you a good clue as to what's going on with the visual field. So that's about the difference in a neurology and a glaucoma setting. A 24-2. So what is the guiding principle? Now, I'll take a little more time here because my last question is a very short answer. So is it okay?
That's okay.
So, yeah. So now, what is the guiding principle between all of these programs, 24-2, 30-2? So if you see a patient who has an optic nerve problem, like you see that patient has a disc edema, patient has a pale disc, you are likely to find a visual field defect even on 24-2. If patient complains of a visual field defect, your optic nerves are normal, you know that maybe you're dealing with a peripheral visual field defect, and these are the patients where you will go with maybe 60-4 or 120-2, where you don't find anything in the central visual field and the optic nerves are normal. If you find a very advanced visual field defect on 24-2 or a 30-2, you may also would like to perform a 10-2 because that can give you within that dense central scotoma that can give you a pattern on a 10-2. So to conclude, automated visual perimetry is what is most popular now even for neurological disease. What we require is a fast program because many of these patients may not be able to do a very long test. So a CETA fast 30-2 or a 24-2 is something which I would advise in most patients.
Thank you, Dr. Ashwin. That answers an interesting question that most of us have when prescribing this test. Second question is, does visual rehabilitation therapy such as Nova Vision help patients with homonymous hemianopias or any other type of visual pathway defects?
So, unfortunately, this does not have a very clear yes or no answer. I mean, it might have to be saying depends on a lot of issues as to when patient got hemianopia, what is his age, and which is the group which is treating, because this requires a lot of effort from both the patient and the group which is treating or administering this visual restoration therapy. Now, I don't have any personal experience with Noah Vision, but the group with whom I was working in Chennai, we had a series and we had published it as well. We had a series where we looked at a different program called Sante Vision, and we also had patients who we treated with prisms. So let me briefly talk about the prisms, and because generally we have been doing both together. Now, there are two types of prisms which are used in homonymous hemianopia. What is the role of prism? Prism would make patients aware about what's happening in their blind field. So if somebody who has a dense right homonymous hemianopia, he is not able to see anything on your right on his right side, and prism would make him aware as to what's going on. So it sort of expands his visual field a little bit. Now, there are two types of prism which are being prescribed. One is a ground prism. That's easy to make, but the problem with a ground prism is that you cannot really prescribe or administer a very hard diopter. Generally, around 6 diopter is what you can prescribe in a ground prism. It does not expand a visual field by much. So there is now popular prisms called Pelly prisms, which can expand. They are like a Fresnel prism. They are clip-on and they can expand fields significantly. But in isolation, it takes around 4 to 6 weeks before patient can get used to these prisms. And the hit rate of patient being satisfied or reporting increased quality of life or being aware about their blind field is 50 to 55%. Not everybody, despite the best effort, would come back and be satisfied with the prisms alone. And that's where this vision restoration therapy, like Noah Vision, which is one company which administers this, is useful. So what is the basic principle of these VRTs? Principles of VRT again is to train the patient using his saccadic movements and his head, and also train him with stability of his gait and whatnot. So basically, it's a center vision is a full package where patient is trained with making saccadic movements towards the blind field, head thrusting, and all this with prism. The number of patients who will come back and report saying that they are more now, they are able to see a little more, they are able to perform more activities or move around a little more easily than what they were before their institution of the therapy. Number goes higher when it's prism with one of these VRTs. One has to understand that in homonymous hemianopia, there are patients who may have a macular sparing. These patients already have a good reading ability, and generally they go by without really any treatment because they are able to read and use mobile and iPad. The problem, of course, of movement is not solved by any of these. So that's my conclusion is VRT seem to have a role, though it is not really very popular with everybody, 100% of the patients. Instituted with Prism has worked very well in our hands.
Thank you, Dr. Shafrin. That clears up a few of the doubts that we had. So we are going on to the next question directly. So here we are talking about a patient who has, again, vascular risk factors. And this particular patient may present with a mononeuropathy. So either one of these nerves are affected, the third, fourth, or the sixth. They already have vascular risk factors. Would you do neuroimaging on these patients?
All right, lovely. So Aruna, you already ruled out my fourth point, which is multiple cranial nerve palsy. There is no debate. If there is more than one cranial nerve is involved, that patient should get a neuroimaging. Now, when I say more than one cranial nerve, it's not only third, fourth, and sixth. Even if the patient has involvement with the seventh nerve or even loss of corneal sensation, fifth nerve, they're all considered as polyneuropathy, and they should be given neuroimaging. Now, fourth nerve, the common causes which would cause a fourth nerve palsy would be congenital and trauma. So, and then ischemia, and then anything sinister. So, fourth nerve threshold, isolated fourth nerve palsy, nothing else, patient in a vascular risk factor, the threshold for neuroimaging is not that high. Patient can be followed up regularly to make sure that it is not going into a multiple cranial nerve palsy. However, the situation or the case is different with the third and the sixth nerve. Dr. Alibar mentioned beautifully about the third nerve. This third nerve, you always worry that is the patient who has a third nerve palsy, is he harboring a posterior communicating artery aneurysm? Why you're worried about it? Because this aneurysm has a propensity to bleed, causing subarachnoid hemorrhage. 50% of these patients actually can pass away before getting a medical attention. And the incidence of having a permanent morbidity is also very high with the third nerve palsy. So no question, again, third nerve palsy, if patient has involvement of pupil or has aberrant regeneration, these patients would get, irrespective of their age or their vasculopathic risk factors, they should be given neuroimaging. The question now is a third nerve palsy with no pupil involvement. In this, if the third nerve palsy without pupil involvement, but if it's incomplete, they should be given a neuroimaging. They should be treated as a pupil involvement third nerve palsy, and they should undergo a complete examination, including angiography. A complete third nerve palsy with no pupil involvement. How do you deal with it? Please remember, 86% of the patients who have an aneurysmal third nerve palsy, they present with pupil involvement on presentation. So if you flip this statement, what it tells you is that 14% of the patients who may be having aneurysm can still present with normal pupil and a complete third nerve palsy. So if you don't advise neuroimaging when the patient comes to you, because he is in the age group and has a vasculopathic risk factors, he should be followed up very regularly every few days to make sure that pupil is not getting involved in the subsequent visits. Because as Dr. Aliboy said, pupil involvement is really a red flag. So third nerve palsy, complete third nerve palsy, no pupil involvement, two possibilities. Follow up the patient and make sure that pupil is not getting involved. However, there is now enough literature. There was a paper which was presented a few years ago by Dr. Madura from Philadelphia and a large group where they reviewed these patients, vasculopathic age group, vasculopathic risk factors, and then they said, are we still missing out? And there was a significant number of patients where they missed out a compressive lesion of third nerve, though clinically it appeared like an ischemic third nerve palsy. So now the more and more people think that if logistic allows you, and logistic means availability of MRI in our settings or the patient affordability, maybe every third nerve palsy, irrespective of presence or absence of vasculopathic risk factors, should be considered for neuroimaging, because what you are missing out is so fatal or so sinister that you probably would like to say, maybe spending extra money, but you don't want to miss out on something which can be potentially fatal. So that's a thought. We still don't do it for everybody. We still follow up these patients. Don't do it in third nerve. Six now, anybody who develops six now, irrespective of vasculopathic risk factors, below the age of 50, you should get neuroimaging. Because six now is also called a tumor now. The base of skull tumors can present to you with isolated six nerve palsy. So a younger patient should get neuroimaging in patients with six now below the age of 50, and we published this series from Chennai in Indian Journal of Ophthalmology around 5-6 years ago. Dr. Andrew Leaf also has published a similar series of yield or neuroimaging in the patient with six now. Above 50, vasculopathic risk factors, again, make sure it's mononeuropathy and follow them up every week to make sure that the other cranial nerves are not getting involved.
Thank you, Dr. Ashwin. A very clear message passed across to all of us, and it's always good to refresh our memory on these important life-threatening conditions and how and when we should be investigating. Last question to you. Should I do the topical pharmacological testing in a patient with Horner's syndrome?
I don't know, I'm going to save a lot of time for you, and I've said that no role in clinical studies. I'll tell you why. And we joke around to say that, well, when you say pharmacological test, you're talking about cocaine and hydroxyamphetamine. And we always ask when someone answers saying, oh, no, I would like to do the cocaine test. We say, okay, what's your source of it? Because it's very difficult for me to get cocaine. So if you have an easy access to cocaine, well, just go ahead and do the cocaine test. But why were we doing these pharmacological tests? Is to localize the lesion as to what would have caused Horner syndrome. Now, because of the improved advanced neuroimaging techniques and more clinical knowledge, I would rather go by patient system. If patient has an acute onset Horner syndrome, complaints of severe face pain or upper neck pain, you know the patient would get neuroimaging, and patient ideally should also, you want to rule out carotid artery dissection. So patient should also be imaged for neck vessels. Patient who has a subacute onset of neck pain, lower neck pain, you're looking at probably a apex of lung. Again, patient should get the neuroimaging of the neck. Patient who has a cyclical unilateral headaches, patient should get MRI brain, and these patients may be having trigeminal neuralgia. So in other words, localizing what would have caused Horner syndrome, acute onset Horner syndrome, again, your threshold for neuroimaging has gone low. The neuroimaging is likely to localize what has caused Horner syndrome. Lack of availability of the pharmacological agents. My conclusion is that actually now there is no role in clinical safety except the knowing of this test by our trainees, because you may still be asked about this in your exams. Thank you.
Thank you, Dr. Rashmin, and very clear and very precise answers as always. It's a pleasure to listen to you. If you possibly can, if you can stay on for another 15 minutes towards the end, we might have a few questions from the audience. Next speaker is Professor Dan Melia. Is he online?
Yes, hello. Can you hear me?
Yeah, good afternoon, Professor Dan. It's lovely to speak to you again, and hopefully you can hear me clearly.
I do.
Yeah, right. So we have 3 questions to you, and all of these are on the same topic. So I won't disturb your flow of thoughts. So I'll ask the 3 questions straight away, and then probably you can continue your speech. So the questions that we have directed at Prof. Dan is, what is the treatment for giant cell arteritis? Should I do a bilateral or unilateral temporal artery biopsy in a suspected GCA? Should a patient with GCA have fluorescein angiography? Over to you, Prof. Dan.
Thank you very much. So I will speak freely if you don't mind, or rather than showing slides. I would just like to thank Dr. Dipani and all the committee inviting me. I am very how can I say, frustrated of not being there. It's always such a pleasure to be in Sri Lanka, and I had the privilege to be there a couple of times. Also, it would have been great fun to reconnect with Rashmin and all the dear friends who have been discussing neuro-ophthalmology in past years. So thank you so much for your invitation. So giant cell arteritis is an interesting disease, and it is a notoriously disease happening in Northern Europe far more often than in Asia for sure. And I think that Sri Lanka is somehow in between. I mean, I worked 12 years in Singapore, and GCA basically was almost non-existent until Dr. Barry Cullen, you must have known Barry Cullen, who diagnosed a couple of patients with GCA in Chinese. And that was so unusual that little by little, we started to discover more and more patients with GCA, presenting most commonly to us as neuro-ophthalmologists as AAION. So trying to address your questions, treatment of GCA. So there are a couple of situations. Either you are absolutely certain that this is GCA, and this is, in my experience, so rare. It's very rare that patients come with a textbook presentation, you know, with all the systemic signs, all the cranial signs, all the visual symptoms and signs. And AAION obviously is the most common sign. CRAO, not as common, but is a possibility. And then, of course, everybody knows, and that's a simple situation. The patient, first thing, that is not written in the books, but my experience, have the patient lie down immediately. This patient should not sit or stand anymore. You just want to increase perfusion to the carotids, into these eyes and brain, because as we know, neurological accidents can happen in GCA. So that's the first thing. Second thing, for about treatment, I think the main pillar of treatment remains, despite all our modern era, is still steroids, acute, urgent steroids. And that should be in case of visual loss, should be IV steroids for at least 3 to 5 days, followed by a very slow tapering oral steroids based on the ESR values. So I think there is no discussion about that. And also, since steroids have side effects, as you all know, there are some new attitudes of steroid-sparing agents. And number one drug today, I think, in our world, and I'm convinced that's your case too, it's tocilizumab. It is an IL-6 inhibitor, which is very efficient at sparing and reducing, in fact, the quantity of steroids. So that is a very important thing. How to deal with the treatment in the long run? Honestly, I do not think that an ophthalmologist should take care of this, because this requires a very careful evaluation of the patient's general symptoms. ESR values are probably the most reliable parameter to rely on. The risk being that patients can relapse, and you never know if you went too far when you're tapering or too fast, and that is one of the major concerns. I just heard about a patient, a terrible patient in a situation in our practice. This is a patient with known polymyalgia rheumatica, PMR, and she's losing vision in one eye. She's calling her doctor, and her doctor says, go to the emergency room. She's not young. She cannot go there. And she just goes up from her 20 milligrams of steroids for her PMR. The doctor tells her, go up to 60. She goes up to 60, and the next day she goes to the emergency room, and she has indeed an ischemic optic neuropathy. And the doctor who takes care of her in the emergency room says, okay, let's see the ESR value. And the ESR value is 5. And he says, okay, under these conditions, I think this must be an NAION. Of course, patients with PMR can have NAION, which is not that uncommon. And he says, since ESR is low, CRP is low, yeah, that's fine. You can go home. Should be fine. So this was my first question, but I'll just extend with the second one. And the patient goes home, and guess what? 6 hours later, she's losing vision in her second eye, comes back to the hospital, has a temporal artery biopsy, which is positive for GCA. So as you probably know, there's a continuum from PMR to GCA. It's always very difficult to know how aggressive you should be with your treatments. I would say, and especially those patients who are older, they also have vascular risk factors. And we've been in situations where patients have been treated for presumed GCA, and their diabetes just goes overboard, and massive complications, acute complications of steroids. So it is a very difficult balance, I have to say. But if you have this luxury of treating, it is an irreversible condition, as you know, and missing one eye, not treating immediately, causes 9% loss in the other eye without treatment. So coming to investigations, the second question you asked me is, but this is very debatable. This is, what I mean very much about those meetings, all the live and lively discussions about what to do. So temporal artery biopsy is still today, I think, the gold standard for diagnosing giant cell arteritis. But you might think, what do we learn this morning from Dr. Dan? He just tells us everything we learn as medical students. Well, no, there are new things. So there is the European Society of Rheumatology, EULAR, and their recommendations about diagnosing giant cell arteritis now, it's explore the temporal arteries with ultrasound. That's the new thing. The problem is that it is very operator dependent, but it is still a very sensitive sign. So what is new when it comes to, so I still think temporal artery biopsy, I'm not even going about, one side or two sides, temporal artery biopsy. I'm talking about other things that should be considered before you go into that. And that is, number one, ultrasound of the temporal arteries, looking at a halo sign, but you need for that a very experienced guy who knows what he's dealing with. And of course, when those patients are coming on Friday night at 11 p.m., this expert is never in the hospital. So what are the alternatives? I still think that a transorbital ultrasound is a very good thing to look at a PSV and various parameters of perfusion in the orbit, which can be quite sensitive for giant cell arteritis. There are two new things also is the PET scan. So this is FDG, it's a contrast, FDG PET CT scan. Why? Because there are, as you know, giant cell arteritis is not limited only to the cranial part. And one of the biggest problem in giant cell arteritis is large vessel involvement. So that an uptake of those vessels is very indicative of giant cell arteritis. Also, you can do MRIs of your temporal artery or looking at the MRIs because you're probably going to do anyhow. And somebody who has a severe headache and visual loss, of course, ESR CRP is the first thing to do and the very basic thing. Nothing has changed about that. But you still want to do probably an MRI. And then there are some new sequences. This is called the black blood. Basically, there's a sequence, it lasts less than 8 minutes. Every radiologist has it. And just suppressing the flow of the blood, that's why it's called the black blood, allows you to look at the thickness of the arteries. So it is quite surprising. Still in evaluation, but my colleagues in Copenhagen in Denmark have wonderful experience with that, showing thickening of the vessels of the carotid or the temporal artery and all along. So that is a very useful, I would say, test to explore temporal giant cell arteritis. And that brings us to temporal artery biopsy. Temporal artery biopsy, again, it's difficult to organize, especially in an emergency setting. It has a lot of false negatives. The specificity is very good. So if it's positive, you can be sure this is GCA. But if it's negative, then you're in trouble. And the sensitivity as can be as low as 30%. The best sensitivity in the literature is something like 77 to 80%. That's not a phenomenal test. 80% of sensitivity, that still means that TAB misses 20% of patients with giant cell arteritis. So this is why your question becomes pertinent. Should I do it in both eyes? Well, I would say not. There are a couple of studies showing how much do a second temporal artery biopsy improve the diagnostic yield. And the results are not impressive. So I think as a very common sense question is doing temporal artery biopsy, try to do it on the side where there is AAIOM or CRAO, or if the headache is lateralized, hoping that the inflammation, the granulomatous inflammation, could spread in that on that side. And if it's negative and you are super convinced, anyhow, what is very important, try to do the second one. Again, the added value of the second one is not phenomenal, depending on studies. But anyhow, I think what is critical is not to wait for temporal artery biopsy. If you are fearing giant cell arteritis, treat immediately. You still have, of course, the longer you wait, the likelihood of the biopsy to pick up inflammation and the diagnosis, a firm diagnosis, is lowering. But I would say a couple of days, it's still reasonable. If I'm starting, we're Saturday, a patient seeing now, I will start him right away. And I'm sure that on Monday, the likelihood, if he really has GCA, would be not that bad to pick up the disease. And your third question, which I think was very interesting, is should we do fluorescein angiogram? And I think this is a very appropriate question because you know what, we just don't do it anymore. And I think it's a mistake because, in our practice, I don't know about you, but everybody gets an OCT and then we just inject that into new algorithms, try to look at artificial intelligence. And in fact, we developed in Singapore, an artificial intelligence-based algorithm trying to discriminate on a simple photograph. Just look at a color photograph, ask the machine to discriminate between arteritic versus non-arteritic ischemic ocular neuropathy, and that has a phenomenal value without any additional investigation. Of course, it's not validated in prospective studies. It's not going to be on the market anytime soon. It needs serious validation. But I still think that fluorescent angiogram is a phenomenal thing with high value because you're just looking at choroidal hyperperfusion, which is a very simple indirect sign. And we as ophthalmologists, we have the means to do that. And honestly, in older times, I would have done CRP, ESR, and do the FA, trying to look at the choroidal hyperperfusion. I think that is a very good question. And I will probably stop there for now for a very quick overview of your three questions. And opening for discussions if there are any questions.
Thank you, Professor Dan. I think we got quite a bit of clarity regarding the questions. It was quite straightforward, and thank you for enlightening us regarding the new developments that are there in the field as well, though we have not come across this in the recent time. Yeah. So this kind of brings us to the end of the talks. We have time for questions from the audience as well as the speakers. First of all, I'd like to open the floor to the speakers if they have anything that they want to add because of the time constraint that we have to finish up. Anything that...
I have a question for Rashmi.
Can I say something? So, okay.
Sorry,
Sure.
go ahead.
Go ahead, Professor Dan.
Okay. No, I really enjoyed the expertise of all the speakers. I think it was just wonderful. I just want to stress something that has been said about a questionable intracranial hypertension without papilledema. And as this was said, it's a very rare and questionable situation. What I think is impossible is to have raised intracranial hypertension and visual loss without optic disc swelling. That is just not possible. I don't know what the panel thinks about that.
We didn't hear the question, we didn't hear the statement, Prof. Dan. You were saying about idiopathic intracranial hypertension without visual loss?
No, without papilledema. And that entity exists for sure, although very rare, and that was clearly expressed. I think what is not acceptable, raising a big red flag, is a patient with high intracranial pressure, IIH, let's say, no papilledema, but visual loss. Right? We see those patients. And,
He's inquiring about patients who have IIH without papilledema, but having a visual loss. Any comments on that, Dr. Ali Boy?
No. So if you just, I can paraphrase, and what he's saying is that you can have raised ICP without papilledema because of the local anatomical factors of the optic nerve. But what you can't have is that raised ICP, no papilledema, but vision loss. Because the vision loss is because of, generally most of the time is a secondary phenomena because of that fluid which is causing that axonal compression. So I think Dan's point is that if you see a patient that you're suspecting raised ICP, you didn't find papilledema which you were supposed to find. But if you find patient having a vision loss, you might have to revise your diagnosis and you might be looking at something.
Can I just comment on a patient that I've managed recently, coming with headache, and patient did not have papilledema but had visual obscurations. And then the headache also was not like a IIH headache. It was more like a migrainous headache, but it's a routine investigations. The MRI was performed and the MRI showed tortuous optic nerves with the empty sella and stenotic transverse sinus and so on, which were indicative of evidence of high raised intracranial pressure. So subsequently, a VEP was performed because of the visual obscurations, which showed amplitude drop. And sometimes VEPs can be used as a monitoring thing for IAH as well. So this patient actually did not have actual visual loss as such, but had visual obscurations, and the CSF pressure was over 400 millimeters of CSF. So it was very high, and patient was treated as IAH, and she improved, but did not have papilledema throughout her illness.
Right. Yeah. Can I also comment on something very interesting related to what you are saying? We're seeing, I don't know about your experience, but in our experience, we're seeing more and more patients who are referred to us evaluation of intracranial hypertension because the MRI is indicative of intracranial hypertension. I'm sorry, there is no such thing. Idiopathic intracranial hypertension, it's still a clinical diagnosis, and MRI can be consistent with that. May be indicative, but certainly not diagnostic. I don't know what people of this audience thinks.
Yeah, I think I will agree with that. You cannot purely go only on the MRI because these are all very, I would say, very soft signs. Just a tortuous vessel, little dilated, CSF around the optic nerve, things like that. You just cannot diagnose, raised intracranial on that. I think they usually require at least more than 3 features on the MRI, 3 features on the MRI to be, confident that this may be raised intracranial pressure on the MRI. But you just can't go just by looking at empty sella or little stenosed transverse sinus or something like that and just say this is raised intracranial pressure.
Can I respectfully disagree with you, sir? I don't think that even with 3 signs, you can say this is intracranial hypertension. You still need a lumbar puncture as a diagnostic parameter.
Would you say that lumbar puncture would be the definitive?
Oh, absolutely.
Definitely, lumbar
Absolutely.
puncture. Yes. Lumbar puncture will be definitely, but problem is that we see reports coming from radiologists and neuroradiologists saying this scan is suggestive of raised intracranial pressure, and then the ball falls on us to disagree with them and completely reject that report, or else confirm the diagnosis by doing a lumbar puncture and excluding. So that is a little tricky when a patient brings a report and say this scan is showing raised intracranial pressure. It is a little tricky for us to just reject that report and just do nothing. And in case it turns out to be raised intracranial pressure with somebody else doing a lumbar puncture, we are in trouble.
No, I agree with you. I don't think that the report should be rejected, but I think the clinical evaluation is still absolutely critical. If the patient, there have been a couple of series shown that MRI signs are not necessarily diagnostic. So start again with your very basic clinical skills, headache, pulse tinnitus, papilledema, obscuration, all those things are still very critical. I'm not saying all those patients should have a lumbar puncture. I'm not saying they should be, the diagnosis should be rejected, but I'm just saying, careful. Those signs are more and more seen, and we have more and more patients sent with those things who do not have IH. Rashmi, what do you think?
Absolutely, I agree with you, and I just wanted to expand, since I know that there are a lot of trainees in the audience. So a very important point was raised about transient visual obscuration, something as an ophthalmologist we should be asking all patients who have, and a few characteristics which will point, saying that maybe this TVO you're dealing with something connected with raised ICP. The TVOs, the transient visual obscuration of papilledema, generally would last for a few seconds versus the vascular insufficiency, which lasts for a few minutes. They are generally described, they're associated with posture. So it is brought about when the patient gets up from a supine position. and it is described as browning out of vision. So, I mean, this is more for trainees that these questions should be part of your workup of a patient of a suspected raised ICP.
Thank you. Wonderful discussion. Dr. Deepani, you had a statement.
Yeah, my question is to Rashmin. I think we see fungal infections in our part of the world. So sometimes I have had at least one case, probably a second case, of patient presenting with isolated sixth nerve palsy. While waiting for because we normally have a long waiting list for cold cases of MRI. Unless we admit and do it urgently, it will take some time. So during that time, the patient, within about 2 weeks, the patient came with a full frozen eye with blindness. So it was found to be a fungal orbital infection. Have you come across patients like that? And like, is there well, this patient was diabetic as well. So could we sort of push? Because normally, I think you said sixth nerve palsy always do MRI, always do neuroimaging, which was good news, good advice for us, because we sometimes think that sixth nerve palsy in a diabetic could be just a vascular, and we tend to sort of, get a cold date for MRI.
Absolutely. In fact, in our series, apart from a fungal infection, we had a patient who actually had a pharyngeal carcinoma presenting as isolated sixth nerve palsy. So patient had a sixth nerve palsy, patient was being followed up, and then later on in the disease, later on, within a few weeks, the other signs were uncovered. So absolutely, as I've been saying, the third and the sixth nerve, there is enough literature now to say that the reason you will not do neuroimaging would be more logistic than scientific, because the things that you're missing out is much more sinister than a disappointment of, maybe a joy of having a normal MRI as far as the patient is concerned. But most of the time, it's the insurance, the payment, or the availability, which precludes the neuroimaging rather than a very sound scientific. Because, as I said, there have been series which has clearly said that very ischemic looking palsies, especially third and sixth, turned out to be much more than ischemic. And what's your view?
Yeah, can I add something? So I think, Rashmin, that you would have not done the statement 10 years ago. It probably would have said, oh, no. So I think that's really a big change in our approach. And I absolutely fully agree with that. I think that these days, pretty much everyone with a palsy needs imaging. And as you said, access to imaging can be delayed, etc. So in Asia, so in probably more Chinese population in Singapore, during that delay to have the MRI, everybody went to an ENT doctor because of NPC, nasopharyngeal carcinoma. I don't know the situation in Sri Lanka, but in more other Asian countries, it's certainly an issue.
And then during COVID, all of them went to ENT because of Mucor. We had a huge...
Mucor, absolutely.
Yeah, thank you. I think that's a very important aspect that we need to. Any questions from the audience? Yes, Chamira, yeah. You can tell the person that you want to ask the question.
Well, it's just, Paul, thank you very much. I'm Dr. Chamira Bandara. I have two things. One is, in the presence of some kind of advanced glaucoma, how do you diagnose papilledema? That might be a bit challenging. That's what's your advice? And the second thing is regarding transient obscurations. One thing we need to remember is, I think, intracorneal lesions can give rise to some transient obscuration with the eye movement compressing and the optic nerve. Thank you.
Yeah, so meningioma typically can cause amaurosis. So if the patient looks to the right or left, they can have that obscuration in a particular gaze. So very good point, good taken, Dr. Bandara, that lesion can produce amaurosis, which is dependent on the gaze. So every time that patient looks in that gaze, he's likely to have that amaurosis. And that would give you a clue saying that there's something which is more structural rather than just vascular. Now, a good point, I'll take it first and then maybe the panel can come in. Not only glaucoma, optic atrophy. Now the axons have died, and now to have clinically evident disc edema in somebody who had papilledema for many years or was not treated or was malignant raised intracranial pressure, and then the axons died away. Now, is there a recurrence? It's very hard for you to rely now on the disc appearance to say that there is a raised ICP which is going on. And same also applies for glaucoma, because again, the number of neurons have gone down and there's nothing that can swell up so easily. And yeah, it's a very challenging situation. You might have to rely on the history and the clinical examination to point towards what's going on. Not only raised ICP, but how do you differentiate that a patient with glaucoma is now developing a new onset neuropathy, not only raised ICP? The few pointers, especially when the patient is not having a very advanced glaucoma, would be that glaucoma is a disease of an arcuate nerve fiber. So you would have a field effect which by and large corresponds to it. The central visual field is preserved for very long, till very long. Color vision is preserved for till very long. Foveal threshold, if you have done that on your visual field examination, would be normal till very long. So if you have any of these, a central visual field defect, a color vision defect, color vision is papillomacular bundle. Glaucoma does not affect that until it's very advanced. So if you have any of these, you know that you have a superimposed optic neuropathy on somebody who was given a diagnosis of glaucoma.
Thank you. That's. I think that answers the question. Yeah. Anyone from the audience, you can raise your hand. We'll send the mic over to you.
In the meanwhile, can I extend what? Sorry, go Rashmin. I fully agree with Rashmin. Just consider this as a general optic neuropathy, not even thinking about the optic disc-swelling. Now, OCT can be very helpful in that. You know, if somebody who had all of a sudden the OCT gets somehow better. I'm not even saying swelling. I'm saying getting better. That is a warning sign, right? That means that, there is probably some edema. And this is the same thing in patients with papilledema. I'm extending a question. Somebody who has a better OCT in a context of intracranial hypertension papilledema, who gets better, that might not be a good sign either. It could be just because neuronal death. So GCC, to answer to extend the question of OCT, looking at GCC complex could be interesting too. If there is GCC loss in addition to what's been seen in the previous examination, that could be another flag. I would say saying, okay, very low threshold for imaging, as Dr. Gandhi said. I think in those conditions.
Any final thoughts, Dr. Bimsara, Dr. Aliboy?
Just a few comments actually about headache and pupil-involved third nerve. I think most of it was discussed, but one diagnosis that we come across as neurologists is the so-called ophthalmoplegic migraine. So interestingly, these patients paradoxically have pupillary involvement, dilated pupils with headache. And these headaches may not be the typical thunderclap headaches that we see in subarachnoid hemorrhage, but we see them quite frequently. So the patient has a headache, pupil-involved third nerve, and nothing else. And MRI, everything is normal, MRA is normal. So that diagnosis has to come into the differential as well. Of course, having excluded the other more sinister causes, but this is not uncommon. We see quite a few patients, because migraine is common. Ophthalmoplegic migraine usually involves the third and the sixth, and very rarely the fourth. So those cases might have pupillary involvement. So that's important to remember as well.
Important. Anything to add, Prof. Dan or Dr. Rashmin?
Agree.
Regarding ophthalmoplegic migraine?
Well, I don't know in your experience, but what I'm seeing, it's not that uncommon. So clinically, there is first the palsy and then the headache. And then also radiologically is the third nerve, which is most commonly involved, sixth also. And I see very often enhancement of those cranial nerves. I fully agree with what's been said about pupils and stuff, but this, of course, not in the context of sixth nerve palsies. But, I still think that looking carefully at the cranial nerves, I do see commonly enhancement. I don't know what the other panelists feel about this.
He's asking about any thoughts from you? About the same, yeah. Can you state the question again, Prof. Dan? It was not very clear to us.
Oh, I apologize. Is that in ophthalmoplegic migraine, which used to be called, now it's called a painful cranial neuropathy, is that there is usually enhancement of the cranial nerve that is involved, more commonly the third than the sixth, that is enhancing. Does the audience has the same feeling?
Aging, you might see some enhancement of the nerve with contrast, contrast imaging, yeah.
Right, thank you. I think we had a very fruitful and a very interesting session, which probably benefited us all. And this brings to the end of our session. And I would like to sincerely thank Prof. Dan and Dr. Rashmin for always being with us and helping us with our sessions, visiting our country numerous times. And we always enjoyed your speeches. And I would like to also be very thankful to our speakers who took their time off, Dr. Bimsara Senanayake and Dr. Ali Boy. I would like to invite Dr. Deepani to give a small token of appreciation from our college. First, Dr. Bimsara Senanayake. Thank you for coming over. And Dr. Ali Boy. Thank you, Dr. Ali Boy, for your very useful contribution. So this brings us to the end of our talk, end of our session on neuro-ophthalmology. I hope you all benefited from it, and I think the sessions continue after lunch. Thank you very much to all the listeners who were there.